afternoon, friends. Next, we are going to discuss pancreatic tumors. So, one of the important topics for exam again, pancreatic tumors. Recently, there are so many questions from this topic. Let us have a detailed discussion on pancreatic tumors. So, pancreatic tumors. So, in pancreatic tumors, we are going to discuss about three types of tumors. They are adenocarcinomas, which are more common among all the three, which I am going to discuss. Adenocancers. Then what else? Endocrine neoplasms. Then cystic neoplasms. Cystic neoplasms. So these are the three types of tumors we are going to discuss in this chapter, and in this, adenocancer is most common of the three. So these are the three types of tumors you get in pancreas, and in this, we are going to discuss first about adenocancers. Okay, so adenocancers in detail. Adenocarcinoma. So adenocarcinoma in pancreas can happen in following places. So please don't forget the following places you can get adenocarcinoma. So this is the pancreas and the duodenum. So you can get cancer pancreas within 2 cm of ampulla. Within 2 cm of ampulla, within the radius of 2 cm of ampulla, this tumor is known as what? Within 2 cm is known as periampullary cancers. That is known as periampullary cancers. And we can get cancer in head of pancreas. This is in the head. So what are the common places you get cancer in pancreas? Are periampullary cancer, head of pancreas, then in the body and tail, then in body and tail. So now let us discuss the basic points in pancreatic cancers. So in this three, which is most common site of cancer, which is most common site, periampullary or head of body and tail. So the most common site of cancer is head of pancreas. In head of pancreas, what is the most common presentation? The patient comes to you with a typical pain abdomen. The pain will be like a pancreatic pain. It will be there in the epigastric region. It can radiate to the back. It is a pain abdomen is the most common symptom of cancer pancreas. Please don't forget that. And it can be associated with jaundice. Jaundice may be present because of compression of the bile duct. And periampullary cancer, the most common presentation is painless intermittent jaundice. Repeat MCQ for national board exam. Painless intermittent jaundice is a classical presentation of periampullary cancer. So why there is intermittent jaundice? Can you tell me why there is painless intermittent jaundice? The reason is the tumor grows in the periampullary region and it will slough out. The tumor will slough out. As the tumor sloughs out, the jaundice gets relieved. Again, the tumor will grow and again it will obstruct. So this is typical painless intermittent jaundice. And because of this presentation of jaundice, these patient comes to hospital yearly. Yearly presentation is seen in periampullary cancers because of jaundice. So therefore, they have the best prognosis among the three. Among the three, which will have best prognosis means periampullary cancer will have best prognosis because 60% of them will be operable at the time of presentation. 60% of them is operable at the time of presentation. But head of pancreas cancer patients, by the time they come to hospital, only 10% will be operable. 90% of them will have metastasis. 90% will have metastasis and they are inoperable. Please don't forget, 90% will be having metastasis and inoperable. And very, very bad prognosis is seen with body and tail cancer. Worst prognosis. Why? Why there is worst prognosis in body and tail cancer? Because by the time they come to hospital, 100% they have mets. So 100% metastasis is seen in body and tail. So they have the worst prognosis. So please don't forget which is the cancer which is most common means head of pancreas cancer is more common. Which is having best prognosis means periampullary cancer. Worst prognosis means body and tail pancreatic cancers. So these are the cancers, and very important thing what you should know in this pancreatic cancer is genetic factors causing cancer you should know. So what are the genetic factors associated with cancer pancreas? So please don't forget the genetic factors associated with cancer pancreas. What is the most common mutation associated? So most common mutation associated with cancer pancreas from Sabiston. This is a controversial question, but no controversy at all needed because this is what given in Sabiston. KRAS mutation is most common. KRAS mutation is most common. Other mutations are P16, P53 and P16 and P53 are other mutations. Some pathology books will say P16, but that is wrong. The most common mutation is KRAS mutation. So the other mutations are P16 and P53. And what are the syndromes associated and what are the other genes mutation? Hereditary risk factors are they are associated with PRSS gene. They are associated with PRSS gene which is corresponding to trypsinogen gene mutation. Other mutations seen are trypsinogen gene mutation, SPINK1 mutation, SPINK1, and there is other mutation like PRSS, SPINK, cystic fibrosis, transmembrane receptor. And in this place, you should not forget the most important mutation, Peutz-Jeghers syndrome, which is STK11 mutation. So this is having the highest risk factor, 100-fold risk. So which mutation has 100-fold risk is an NBE question. So national board question, which mutation has 100-fold risk of pancreatic cancer? The 100-fold risk is associated with Peutz-Jeghers syndrome. So please don't forget PRSS gene, SPINK gene, CFTR, Peutz-Jeghers syndrome, Lynch, familial adenomatous polyposis, familial atypical melanoma syndrome, familial atypical melanoma syndrome, familial atypical melanoma syndrome, BRCA2 are the various other mutations associated. So Lynch syndrome is nothing but microsatellite instability. So these are the various mutations, and in this, what are the MCQs asked means most common mutation is KRAS mutation is asked, and 100-fold risk associated with Peutz-Jeghers syndrome is asked. So please don't forget these 2 points. Very important for your exams. Okay. So please don't forget the syndromes associated PRSS gene mutation, SPINK1, cystic fibrosis, transmembrane receptor, Peutz-Jeghers syndrome is the one which is causing 100-fold risk. All these syndromes you should not forget. Okay. These are the various syndromes associated with pancreatic cancer. Okay, pancreatic cancer. Now let us discuss the important clinical features. So in clinical features, I told you pain abdomen is the most common feature of head of pancreas tumor. Pain abdomen is the most common feature of head of pancreas tumor. Painless jaundice is a feature of painless intermittent jaundice is a feature of periampullary cancer. So head of pancreas cancer will have pain abdomen, painless jaundice is periampullary cancer. And please remember vomiting. This question is asked 2 times in JIPMER. Vomiting in pancreatic cancer, what is the reason? It is mainly due to the external compression of the duodenum. It is mainly by the external compression of duodenum. By the tumor is the main cause for vomiting. So the main cause of vomiting in pancreatic cancer is by the compression of the duodenum resulting in gastric outlet obstruction is the reason for vomiting. And please don't forget this tumors will obey the Courvoisier law. I hope you would understand what is Courvoisier law from gallbladder chapter. So recall what is Courvoisier law. If there is a cancer, the gallbladder will be enlarged or not enlarged. if there is a cancer in the bile duct, distal bile duct or pancreatic head or periambular region, the gallbladder will be enlarged. So as per Kurwai's law, the gallbladder will be enlarged on clinical examination. Clinical examination shows GB enlargement. If it is due to stone, gallbladder will not be enlarged, and this is a cancer, so there is gallbladder enlargement seen. Please don't forget, there will be gallbladder enlargement seen in these patients. Okay, this is a high yield topic for exam. These are the clinical features. And now coming to TNM staging. So in TNM staging, it's not so important, but usually they ask you T staging in exams. In JIPMER, they have asked 2 times the T staging alone. Just I'm giving a brief outline. So no need to waste more time on all TNM stagings. Read selected TNM stagings. That alone is essential for exam. So less than or equal to 2 centimeter size tumor is T1. It is 2 to 4 centimeter is T2. More than or equal to 4 centimeter is T3. T4 is a tumor involving superior mesenteric artery, involvement of superior mesenteric artery, involvement of common hepatic artery, or involvement of celiac artery is known as T4. So the one question which is asked in JIPMER exam is, so infiltration of SMV and portal vein does not change the staging. Please remember. So by infiltrating into superior mesenteric vein or portal vein, the T staging is not ascending up, but infiltration to artery, the T staging is ascending up. This point is the only question asked in TNM staging. So therefore I request you to remember only this. So T staging, T1 less than 2 cm, T2 2 to 4 cm, T3 more than 4, and involvement of arteries like superior mesenteric artery, common hepatic artery, and celiac artery is known as T4. Involvement of portal vein or superior mesenteric vein does not increase the staging. So based on this staging, we can say the tumors as resectable tumor. So resectable pancreatic cancers, borderline resectable cancers, and unresectable cancers. You should know what are these three. So pancreatic cancers, we should decide whether they are resectable, borderline resectable, or unresectable. So resectable cancers are which are not infiltrating to, there is not infiltrating to SMV or portal vein. There is no infiltration to superior mesenteric vein or portal vein, and there is no mets. That's all. Very well known answer. Resectable tumors will have no infiltration to SMV or portal vein, no mets. Borderline resectable tumors. Please remember, this is the only question which will be asked for your exams. The following are borderline resectable tumors. Number 1, infiltration to superior mesenteric vein or portal vein. Infiltration is present. It is still borderline resectable. Infiltration to superior mesenteric artery or celiac trunk or to the common hepatic artery to angle of less than 180 degree is resectable. So please remember, if the artery is like superior mesenteric artery, celiac trunk or common hepatic artery is infiltrated less than 180 degree, it is borderline resectable tumor, and this is MCQ. So infiltration of superior mesenteric vein or portal vein even more than 180 degree is resectable. Please remember, borderline resectable. Superior mesenteric vein or portal vein more than 180 degree, we can resect the veins and we can do reconstruction or put a prosthesis between them. So they are borderline resectable tumors. Superior mesenteric artery, celiac trunk, and common hepatic artery infiltration less than 180 degree, still we can do marginal resection and reconstruct. So this is borderline resectable. So naturally you know what is unresectable. When the superior mesenteric artery, celiac trunk, or common hepatic artery infiltrated more than 180 degree, we cannot operate them. Okay, when it is more than 180 degree, we cannot operate them. Please don't forget. And if there are mets present, they are inoperable. So please remember this classification based on the infiltration of surrounding structures. So resectable tumors are not infiltrating any vessel, no mets. Borderline resectable is superior mesenteric vein or portal vein infiltrated more than 180 degree. Superior mesenteric artery, celiac trunk, common hepatic artery less than 180 degrees, borderline resectable. And unresectable tumor is this. Okay, this point you should not forget. Don't forget the TNM staging and borderline resectable points in pancreatic cancer. These are all not usually asked in national board exam, but these are high focus points from JIPMER exam. Okay, please remember these points. Okay, now coming to the national board focus area, investigations. Investigations of pancreatic cancer are the following. So what is the investigation of choice for pancreatic cancer means? It is CECT abdomen. CECT, contrast enhanced CT abdomen, which is pancreatic protocol CT. What is this pancreatic protocol CT? Pancreatic protocol CT is a CT. Usually the contrast enhanced CT scan, the cut is made at every 5 mm cut. In pancreatic protocol CT, near pancreas, the cut should be made at 2 to 3 mm cuts, so that any small lesion, infiltration to surrounding vessels, everything can be detected. 2 to 3 mm cut at pancreas region is known as pancreatic protocol CT. Pancreatic protocol CT. So normally we do 5 mm cut. Here you do 2 to 3 mm cut. That is the investigation of choice for pancreatic cancers. And what is the tumor marker? So pancreatic cancer diagnosis as well as investigation, everything is CT abdomen. The tumor marker is CA19-9. This is an expected MCQ. Please don't forget. CA19-9 is a tumor marker of pancreatic cancer. Please don't forget, CA19-9 is a tumor marker of pancreatic cancer. And what are the other investigations? ERCP sometimes done to take biopsy from the periambular lesions, but not essential. It is not a compulsion. But on ERCP and on MRCP, in a pancreatic head cancer, you will get one sign. What is that sign? In a ERCP and in MRCP, you get a sign. What is the name of this sign? What is the name of this sign? The bile duct will be seen like this, the pancreatic duct will be seen like this, and there will be a lesion here. What is this sign known as? The two ducts are dilated and separated, known as double duct sign. The two ducts are double duct sign, and not done commonly, but when you do barium meal for a cancer pancreas, when you do a barium meal, they will have one sign. What is it? What is the sign? The duodenum will be tractioned towards the pancreas, towards the head of pancreas like this, looking at appearance. What? This appearance is known as Frostberg sign. This sign is known as Frostberg or reverse 3 sign. Frostberg or reverse 3 sign, also known as epsilon sign. So all names are for same. So in a cancer head of pancreas, the sign seen as Frostberg sign, reverse 3 sign, or epsilon sign. All these are various names for barium meal. So tumor marker is CA19-9. ERCP shows double duct sign. Barium meal shows Frostberg, reverse 3 sign, and epsilon sign. All these are various investigation findings. So please don't forget, for cancer pancreas, investigation of choice is CT abdomen. For a cancer pancreas, biopsy, is it must or not needed? Biopsy is not needed if you are going to operate. Biopsy is done only when you are not going to operate. When you are going to give palliative chemotherapy or radiotherapy, then only we take biopsy. Otherwise, biopsy is not needed for operable cancers. Please remember, pancreatic cancers, biopsy is not needed for operable cancers. Only for inoperable cancers, you should take biopsy. Inoperable cases, we can take biopsy by CT guided biopsy or EUS guided biopsy can be advised. In case of inoperable cases, just for palliation, we want to give chemotherapy or some other medical management, we will go for biopsy only for inoperable cases. Operable cases, no need of biopsy. Directly we can operate those patients. Okay, so these points you should not forget. And coming now to the management of pancreatic cancers. Please don't forget the management of pancreatic cancers. So for an operable and resectable cancers, please remember, for an operable and resectable cancer, the treatment is straightforward. What surgery? Operable and resectable cancer, the straightforward operation is, the treatment of choice for a cancer head of pancreas and periambular cancer is pylorus preserving pancreaticoduodenectomy, or second option, Whipple's operation. I'm going to explain them in detail soon. Just know the names now. So Whipple's operation, I will either do pylorus preserving pancreaticoduodenectomy, or I will do Whipple's operation for a operable resectable cancers. For an operable and resectable cancers, I will go for a pylorus preserving pancreaticoduodenectomy, or Whipple's for head of pancreas cancer and periambular. Usually the distal pancreatic cancers are usually inoperable, and if at all they are operable, we do distal pancreatectomy and splenectomy. Otherwise, for head of pancreas cancers and periampullary cancers, we do pylorus preserving pancreaticoduodenectomy or Whipple's. So now let me discuss the majority procedure done by us on pancreas, that is for inoperable patients. Inoperable patients, we do palliative procedures. What are the palliative procedures done? You should know. Palliative means what are the things we palliate? We palliate pain. We palliate the pain caused by the pancreatic cancer. We palliate the gastric outlet obstruction caused by the cancer. We palliate the jaundice for the cancer. So for pain, what are the things you can do? For a palliative treatment of pain, we can give celiac plexus block. Celiac plexus blockade can be given for pain, intolerable pain, that can be treated by celiac plexus blockade using absolute alcohol. And for gastric outlet obstruction caused by this tumor, we can either put a duodenal stenting, we can put a duodenal stenting if possible, or we have to go for bypass, palliative bypass procedure. We'll go for a palliative bypass procedure. And similarly for jaundice, if possible, you can put a self-expanding metallic stent or bypass. For a jaundice, we can put a self-expanding metallic stent, or we can do a bypass for jaundice. So I am telling you bypass. What is that bypass? That bypass is known as triple bypass procedure. So triple bypass is done for inoperable cancer pancreas. What is this procedure? Just understand the image I am drawing. So please understand, there is a cancer here in the pancreatic head which is compressing the duodenum and the bile duct. Let us assume this is a cancer in the pancreas compressing the duodenum and also the bile duct. So you are seeing the gallbladder is enlarged. This much gallbladder is enlarged. So this much gallbladder is enlarged. Now what I will do is, now I want to palliate the GOO, and also I want to palliate the jaundice. So what I will do, I will bring a loop of jejunum from here. And anastomose with the stomach like this. So this is known as gastrojejunostomy. And I will bring another loop here and anastomose with the gallbladder known as cholecystojejunostomy. So see whatever I am doing, I am doing gastrojejunostomy, one bypass, so that the food will go directly to the jejunum. Another bypass, cholecystojejunostomy, so that the bile will go inside. And to prevent the food going into the gallbladder, I will do another anastomosis here. This is known as jejunojejunostomy, because otherwise what will happen? If I am eating an idli, this idli will travel. How it will travel? This idli will go like this, it 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 will go like this. It will unwantedly go to the gallbladder. To prevent it going to the gallbladder, I will make it go like this. That is the third anastomosis, jejunojejunostomy. So triple bypass, the operations done in triple bypass are GJ, cholecystojejunostomy, JJ. These are the triple bypass operation done for inoperable pancreatic cancers. Inoperable pancreatic cancers, to palliate GOO and to palliate jaundice, we do this cholecystojejunostomy, gastrojejunostomy and jejunojejunostomy. And please remember, this procedure will not palliate the pain. You can put a celiac plexus block simultaneously also. Intraoperatively, we can put a celiac plexus block for these patients. So this is mostly done procedure. Most of the time for inoperable pancreatic cancers, we do this procedure only. So I told you already, periampullary cancers only 40% are operable. Head of pancreas only 10% are operable, and for those cases we do commonly in practice we are doing the Whipple's operation. But what is Bailey saying is you must do pylorus preserving operation. Let me first discuss Whipple's. What is Whipple's? Whipple's is a high yield MCQ topic for your exams. So please understand how I am drawing Whipple's. So I am going to draw the picture of Whipple's operation now. So please understand the picture I am drawing. Just I am not making anything complicated. Just I am making it so simple. So now you see this is pancreatic body and tail, which is normal pancreatic body and tail, and this is normal pancreatic body and tail. This is normal proximal bile duct. This is normal proximal bile duct. So now there is a cancer in this place, like let us assume this is a head of pancreas cancer. Now what I am going to do is I am going to resect this head of pancreas. This procedure is known as Whipple's procedure. Whipple's procedure is a dream operation of any surgical gastroenterologist. So especially when we are a PG, we love to do Whipple's operation. We were craving for chance for a Whipple's. Only those who work like a slave in the PG period will be given a Whipple's operation. Okay, such a way the Whipple's operation is one of the most dreamt and most lovable operation by any gastrosurgeons. So what we do in Whipple's, because in Whipple's we deal with the stomach, we deal with the intestine, we deal with the bile duct, pancreatic duct, entire organ inside the GIT will be dealt in Whipple's. So one of the lovable operations. In Whipple's operation, what are the structures removed? I am highlighting. I will remove the distal stomach. Please understand, I am removing the distal stomach. I am removing distal stomach. I am removing the entire duodenum. Whatever I am highlighting as yellow color, I will remove. Entire duodenum up to small part of jejunum. I will remove the proximal small part of jejunum. This is DJ flexure, small part of jejunum, and I will remove the up to tunnel of love. We will create the tunnel of love and look for operability, and we remove up to head of pancreas. I will remove the distal bile duct, gallbladder, and this thing will be removed. So after removing this, what will be remaining? After these structures are removed, what will be remaining? The proximal stomach will be remaining. The bile duct will be remaining. Proximal common hepatic duct or bile duct will be remaining. Distal body and tail of pancreas will be remaining. Now I will bring a loop of jejunum. And I will do the three anastomoses. What are the three anastomoses done after Whipple's? Pancreaticojejunostomy, gastrojejunostomy, and hepaticojejunostomy will be done. So there are three anastomoses done. So pancreaticojejunostomy, gastrojejunostomy, and hepaticojejunostomy. So three anastomoses are done after Whipple's operation. So in this Whipple's operation, this is one of the major surgeries. It will take from 4 to 8 hours to complete this operation based on the patients. We have around 4 to 6 hours surgery, and three anastomoses are done. So what are the structures removed? Is the first MCQ from this surgery. Structures removed in Whipple's, or structures removed in pancreaticoduodenectomy are stomach, part of stomach. Okay, part of stomach. Entire duodenum. So please remember, this is a neat question. Entire duodenum will be removed. Bile duct will be removed. Along with the gallbladder will be removed. Head of pancreas is removed. So these are the structures removed. Gallbladder, head of pancreas, up to tunnel of love is removed. And after removing all these structures, the anastomoses done are GJ, HJ, and pancreaticojejunostomy. So what is the most important anastomosis in this thing? Most important anastomosis, also known as Achilles heel of Whipple's. What is also known as Achilles heel? Achilles heel of Whipple's operation is pancreaticojejunostomy operation. Achilles heel of Whipple's operation is pancreaticojejunostomy operation is the Achilles heel. The most important anastomosis is pancreatic jejunostomy, which is also known as Achilles heel operation. Okay, Achilles heel of this operation. And now the question starts. What is the most common complication of Whipple's? 100 times asked MCQ. Please don't forget, most common complication of Whipple's. Direct line from Bailey and Lowe. It is delayed gastric emptying. Patient will have vomiting and increased Riles tube aspirate. Okay, even after 7 days, patient will be having delayed gastric emptying. That is seen in around 18% of the patient. This is the most common complication, delayed gastric emptying. It's seen in 18% of the patient. So most common cause of death in Whipple's. What is the most common cause of death after Whipple's operation? It is PJ anastomosis leak. Now you can understand why this is known as Achilles heel. Because if the pancreatic jejunostomy anastomosis leaks, just see here. If it leaks, what secretion will come out? Active pancreatic enzymes will come out. That will go and digest all the anastomosis, and automatically all anastomosis will leak. That is why usually the PJ anastomosis is not given to the junior surgeons. Usually the senior most surgeon will come and do the PJ anastomosis. And the suture material used for this pancreatic jejunal anastomosis is what material should be used? Please remember, Vicryl should not be used because Vicryl will be digested by the pancreatic juice. Vicryl should not be used. We should use only proline. Proline is used for pancreatico-duodenal anastomosis. If you use Vicryl, the Vicryl will be digested and patient will develop leak. So the anastomosis is done with the help of proline. So the most common cause of death is pancreatico-jejunal anastomosis leak. And define pancreatic fistula. A patient post Whipple's develops a pancreatic fistula. Means the drain which is kept after Whipple's. The patient had a drain. Usually we keep a drain after Whipple's operation. So after Whipple's operation, we kept a drain like this for the patient, and the drain is producing fluid. And there is a rule of 3 to define pancreatic fistula. Rule of 3. What is the rule of 3? So please remember rule of 3. On third post-op day, please don't forget, on third post-op day, the DT fluid should be sent for amylase. Send for DT fluid amylase, and also send serum amylase. So the DT fluid amylase is 3 times more than serum amylase. So that is known as pancreatic fistula. So please remember, pancreatic fistula we used to remember by a rule of 3. On third post-op day, if the DT fluid amylase is 3 times more than the serum amylase, it is defined as pancreatic fistula. It is one of the morbidities seen in pancreatico-jejunal anastomosis. So these are all the various important points you should not forget. Please don't forget the most common complication is delayed gastric emptying, and most common cause of death is PJ anastomosis leak. PJ anastomosis leak. Please don't forget these points. And I was already telling you there is one operation known as pylorus preserving pancreatico-duodenectomy. So pylorus preserving pancreatico-duodenectomy. Can you tell me why this modification came from pancreatico-duodenectomy? Why this modification of preserving the pylorus came? The pylorus is preserved. I'm not resecting the stomach. I'm preserving the pylorus. Why should this operation come? And when I'm doing Whipple's, I will anastomose with the first part of duodenum will be remaining. That will be used for anastomosis. Anastomosis will be done, or so for example, after surgery, what are the structures remaining will be like this. So I will do anastomosis like this. I will bring a loop of jejunum, and at this time I will do pancreatico-jejunostomy. Please remember, pancreatico-jejunostomy, and here it will be duodeno-jejunostomy, and here it will be hepatico-jejunostomy. Small amount of duodenum will be remaining, preserving the pylorus. What is the advantage of preserving pylorus? Yes, you know the answer. What is the reason? Why should I preserve the pylorus? By preserving the pylorus, there is decreased delayed gastric emptying. Please remember this point. By preserving the pylorus, the delayed gastric emptying complication is less because we are preserving the nerve of lateral jet. So therefore, delayed gastric emptying complication is left. So the delayed gastric emptying complication is not there. So the delayed gastric emptying is less than 1% in these cases, whereas in pylorus removed cases it is around 8%. That is the main reason we are doing pylorus preserving pancreatico-duodenectomy, and the name for this operation is Longmire and Traverso procedure. So Longmire and Traverso procedure. Otherwise everything else is same. So the major advantage of Longmire and Traverso procedure is the pylorus is preserved, so the patients will have decreased delayed gastric emptying. So this is known as Longmire and Traverso procedure. So please don't forget, Whipple's operation is a high yield operation topic. So usually the examiners will be more interested in asking questions from Whipple's operation, and especially this is one of the interesting surgeries by us. So we used to ask more questions from students regarding the Whipple's operation. Just see some of my patients' images of Whipple's operation. Just I'll show you. So see, this is one of the specimen of my patient Whipple's. Just I wanted to show you some Whipple's operation of mine. So this is the incision made. So you can see the incision made for Whipple's is like this. What is the name of this incision? This incision looking like a rooftop. So this is known as rooftop or chevron incision. Please don't forget, this incision is known as chevron incision. Chevron or rooftop incision. This incision is chevron or rooftop incision. So I have made a rooftop incision for this patient. She is very happy because very few patients, around 10 to 20% patients may have mortality after surgery. This patient survivor. So you can see CT scan showing intrahepatic biliary radicals are dilated, and you can see the gallbladder is distended. Gallbladder is distended very much. And you can see the bile duct in this picture. If you see the bile duct itself this much distended, you can note very well the bile duct this much distended. Gallbladder is very much distended. Typical curva is She is a case of periampullary CA. So she is having a dilated gallbladder. So this is, you see, the first step in a Whipple's operation. We are seeing for the patency of tunnel of love. You can see I'm putting an instrument and seeing the tunnel of love is patent. So now I have removed the specimen. You can see the remaining contents. Just focus on this picture for a few minutes. You will understand. So you can see I have removed the distal stomach. This is a conventional Whipple's I have done here. You can see I have removed the distal stomach. So this is one stomach. This is the stomach which is remaining. And you can see this is the pancreatic body remaining. And this is the bile duct remaining. Okay, you can understand. I have removed the head of pancreas, duodenum, and all I have removed. And this is the tunnel of love which is present here. Now after removing all these structures, I will go for a reconstruction. Okay, this is a typical surgery, Whipple's operation. So I'm doing the pancreatic jejunostomy now. So by using ductal mucous anastomosis going on, and this is a specimen of Whipple's. So Whipple's specimen. So you can see the small tumor inside the periampular region. It's a typical periampular region tumor. This is a typical case of Whipple's. So Whipple's is one of the favorite operation of most of the surgeons. Okay. So I hope you understand what is pancreatic cancer. So pancreatic cancers, please don't forget the most common site is head of pancreas. Most common site is head of pancreas. Okay. Now coming to endocrine tumors of pancreas. The next topic in pancreatic tumors is on endocrine tumors. So endocrine tumors of pancreas, the most common endocrine tumor of pancreas is pancreatic polypeptidomas. Pancreatic polypeptidomas. But why many books are not discussing about them? Because though pancreatic polypeptidomas are most common, they are non-functional. They are non-functional and they don't come to hospital many times. So pancreatic polypeptidomas are overall most common tumors of endocrine tumors. They are non-functional, so they don't come to hospital. So we not worry about it. So therefore, what is the most common functional neuroendocrine tumor of pancreas? So these all come under the classification of neuroendocrine tumors, and the most common functional neuroendocrine tumor of pancreas is insulinomas. So please don't get confused. It is insulinomas. If they ask you overall and if there is a choice of PPO mass, you have to go with it. Otherwise, if they ask you functional, it is insulinomas. And in MEN 1 syndrome, please don't forget, in MEN 1 syndrome, it is gastrinomas. Now I'm going to tell you 8 differences between insulinomas and gastrinomas. So please understand and focus these 8 points. Insulinoma is the most common functional neuroendocrine tumor. Gastrinoma is the most common functional neuroendocrine tumor in MEN 1 syndrome. So I'm going to tell you 8 points. Please, usually I take some topics by comparing one with other so that you won't forget both. Okay. So insulinomas, it is equal in head, body, tail. So the most common site of insulinoma is it is equal in head, body, and tail. So the insulinoma is common in head, body, and tail in equal proportion. It is equal proportion head, body, and tail. Gastrinoma is most common in where? You all know the answer. That is Passaro triangle. They are more common in Passaro triangle. What is this Passaro triangle? Please understand what is Passaro triangle. This question being asked in national board exam. So I want you to remember what is Passaro triangle. So I'm going to tell what are the 3 points to say for Passaro triangle. So number 1 point is neck of pancreas. This is 1 point. So neck, the three edges of Passaro triangle. Neck of pancreas, cystic duct CBD junction, cystic duct with CBD junction, second and third part of duodenum junction, second and third part of duodenum junction. So this is a Passaro triangle. So Passaro triangle is bounded by cystic duct CBD junction, neck of pancreas, second, third part of duodenum. So most of the gastrinomas are seen in this triangle only. Most of the gastrinomas are seen in this triangle only. And please don't forget, if this Passaro triangle is not there in the choice, most common site, if that is not there in the choice, go with duodenum. If Passaro triangle is not there in the choice, go with duodenum greater than pancreas. So please don't forget, if Passaro triangle is not there in the choice, you must go with duodenum more common than pancreas. So please don't forget, this Passaro triangle is a common site of gastrinoma. That's the second point I want you to remember. Insulinomas are mostly benign. So keep writing, this is a most benign. Gastrinomas are mostly malignant tumors. They are mostly malignant tumors. Gastrinomas are usually malignant tumors. Insulinomas, clinical feature. What clinical feature insulinoma comes to hospital? Can you tell me? Repeat, national board question again. Insulinoma patient comes to you with a clinical feature of Whipple's triad. That is known as Whipple's triad. The triad is known as Whipple's triad. So what is Whipple's triad? There is excessive insulin production. Therefore, patients will have signs of hypoglycemia. And at the time of hypoglycemia, blood sugar value is less than 40. At the time of hypoglycemia, blood sugar is less than 40. And when you give sugar, that relieves the symptom. Sugar relieves the symptom. So sugar relieves symptoms. So Whipple's triad is characterized by signs of hypoglycemia, blood sugar less than 40, sugar relieves symptoms. These are the points you should not forget. So what are the features of Whipple's triad? Signs of hypoglycemia, blood sugar less than 40, and sugar relieves symptoms. So because of this reason of hypoglycemia, this patient will keep on eating. Therefore, they have weight gain. The tumor with weight gain is insulinoma. The tumor with weight gain is insulinoma. On the other hand, the clinical feature of gastrinoma due to excessive production of gastrin, that is a syndrome known as Zollinger-Ellison syndrome, which is characterized by what? Unusual peptic ulcers. Unusual peptic ulcer disease. What do you mean by unusual peptic ulcer? The peptic ulcer seen in second and third part of duodenum, recurrence of peptic ulcer, even after truncal vagotomy they have recurrence. So unusual site, unusual recurrence, that is known as unusual peptic ulcer disease. Along with diarrhea is seen. Because of hyperacidity, they have diarrhea. So Zollinger-Ellison syndrome is a feature of gastrinoma. Unusual peptic ulcer disease and diarrhea are seen. Unusual peptic ulcer disease and diarrhea is seen. So now coming to the investigation of choice to diagnose. So investigation of choice to diagnose insulinoma is very easy. We can diagnose by measuring 72 hours. 72 hours fasting blood sugar plus insulin level is measured. So to diagnose insulinoma, it is very easy. We have to measure 72 hours of fasting blood sugar and insulin level. And also we can measure C-peptide. C-peptide is seen in endogenous insulin, so it will be elevated. C-peptide value elevated and there is increased insulin level. So the C-peptide helps you to differentiate insulinoma from excessive use of exogenous insulin. So sometimes the diabetic patients, they will use exogenous insulin. So they will also have same symptoms like hypoglycemia and blood sugar less than 40. How to differentiate a diabetic patient having excessive insulin from insulinoma is by measuring C-peptide. C-peptide is increased only in insulinoma. It is normal in exogenous insulin injection. So it is normal in C-peptide is normal in exogenous administration. So this is one important AIMS question. How to differentiate insulinoma from exogenous administration of insulin? So by measuring C-peptide level. So investigation of choice to diagnose insulinoma is this. For investigation of choice to diagnose gastrinoma is by measuring serum gastrin level. How much it will be? Serum gastrin will be more than 1000 picograms per ml. It will be more than 1000 picograms per ml. That is diagnostic. If it is borderline, if the value is not 1000 or above, but it is elevated borderline, at the time we do one test. What is that test? Secretin stimulation test. The test is known as secretin stimulation test. When I do secretin stimulation test, immediately the value increases 200 picograms above the baseline value in 15 minutes. In 15 minutes, the value increases 200 picograms per ml. So please don't forget. So investigation of choice to diagnose insulinoma is 72 hours fasting blood sugar and insulin, and for gastrinoma is serum gastrin above 1000. If there is a borderline elevation, we should do secretin stimulation test, which will increase above 200 picograms per ml in 15 minutes. So what is the next step? You have diagnosed there is insulinoma or gastrinoma. What is the next step? Next step is to localize the tumor. Where is the tumor located? Very big task. Very big task to locate the tumor. Very easy for gastrinoma. Why? Very easy for gastrinoma because all neuroendocrine tumors have a receptor known as somatostatin receptor. All neuroendocrine tumors will have somatostatin receptor. Therefore, gastrinoma is localized by SRS, somatostatin receptor scintigraphy. There is only one neuroendocrine tumor which will have no somatostatin receptor, that is insulinoma. The only neuroendocrine tumor without somatostatin receptor is insulinoma. Therefore, we cannot diagnose insulinoma with the somatostatin receptor scintigraphy. Therefore, we have to depend on other investigations. The first answer for this question to localize is what? Intra-op ultrasound. That is the first best answer. So there are many answers. We don't know what the examiner is going to have. So from my point of examination, I will tell first answer is intra-op ultrasound, second answer is endo ultrasound, third answer is intra-op ultrasound, endo ultrasound, third answer is going to be selective arteriography sampling, which is not done commonly, just for completion. That is selective arteriography sampling. So first answer is intra ultrasound, second answer is endo ultrasound, third answer is selective arteriography sampling to localize insulinoma. And coming to management, since insulinoma is a benign tumor, just enucleation is enough. Just enucleate the tumor, that's enough. No need to do anything, just enucleate the tumor. But carcinoma is malignant, so what you must do? You must do, therefore, Whipple's operation. So please remember, can we do pylorus preserving pancreaticoduodenectomy for this patient? So Whipple's operation is the treatment of choice. Pylorus preserving pancreaticoduodenectomy is contraindicated in carcinomas. Why? Means because the tumor will be present in the residual duodenum. The tumor can recur in the residual duodenum. Therefore, please remember, pylorus preserving pancreaticoduodenectomy is contraindicated in carcinoma. We have to do only Whipple's operation because it is present in Passaro triangle. The treatment of choice for carcinoma is pylorus removing Whipple's operation. We should not do pylorus preserving Whipple's operation. And post-operative chemotherapy. For inoperable and metastatic cases, we have drugs like streptozotocin and diazoxide. Please don't forget, we have drugs like streptozotocin and diazoxide for insulinoma. And for post-operatively inoperable cases, we give octreotide and triple dose PPI in carcinoma. Triple dose PPI and octreotide are given in carcinoma. So high yield topic, please don't forget these points. Every point is MCQ point. So most common neuroendocrine tumor overall is insulinoma. Insulinoma is equal in head, body and tail. So though some books say head as answer, the point which you should follow is head is equal to body equal to tail. So carcinoma is common in Passaro triangle. So insulinoma is benign. Insulinoma follows Whipple's triad and therefore there is weight gain. Carcinoma, there is so much of diarrhea and peptic ulcer, so there is therefore weight loss. Carcinoma has weight loss. So to diagnose, we use 72 hours fasting blood sugar, here serum gastrin. And please don't forget, secretin stimulation test will increase the value to 200 picograms in 15 minutes. To localize, the best answer in insulinoma is intra ultrasound, and for carcinoma it is ECSRS. So management is enucleation for insulinoma, Whipple's operation for carcinoma, and post-operatively we use streptozotocin diazoxide. Here we use octreotide and triple dose PPI. Okay, these are the two important things you should not forget for your exams, insulinoma, carcinoma. What are the other neuroendocrine tumors? Other neuroendocrine tumors of pancreas. Other neuroendocrine tumors of pancreas are glucagonoma, which produces excessive glucagon. Because of excessive glucagon production, the patient will have increased blood sugar, therefore they have diabetes. The characteristic feature of glucagonoma is diabetes plus dermatitis. This is a classical presentation of glucagonoma, diabetes plus dermatitis. So high yield MCQ for your exam, what is the name of that dermatitis? What is the name for that dermatitis? That is necrolytic migratory erythema is the name of that dermatitis seen in these patients. So necrolytic migratory erythema is the name of this glucagonoma. The skin lesion in glucagonoma is known as necrolytic migratory erythema, and the glucagonoma is most commonly seen in head, and it is mostly malignant. Mostly they are malignant and they are seen in head. So glucagonoma, please don't forget, they are associated with 2D, diabetes and dermatitis. And they are most common in head and they are mostly malignant. And one more neuroendocrine tumor which is very rare is VIP-oma, There are many neuroendocrine tumors, but VIP-oma and so glucagonoma may be asked in exam. VIP-oma is also known as VADA syndrome. What is VADA syndrome? What do you mean by VADA syndrome? Watery diarrhea, that is watery diarrhea, hypokalemia, and achloridria syndrome. So watery diarrhea, hypokalemia, achloridria syndrome is known as VADA syndrome. So the syndrome seen in VIP-oma is watery diarrhea, hypokalemia, achloridria. It is also known as Werner-Morrison syndrome. Its other name is Werner-Morrison syndrome. Also known as pancreatic cholera. So VIP-oma is another neuroendocrine tumor which is associated with VADA syndrome, watery diarrhea, hypokalemia, and achloridria, and it's also known as Werner-Morrison syndrome or pancreatic cholera. Can you tell me where is it common? VIP-oma is most common in. I used to remember VIP will have tail. VIP-oma is common in tail. So VIP-oma is common in tail, glucagonoma is common in head, insulinoma is equal in head, body, tail, carcinoma is common in duodenum. Okay, please don't forget the neuroendocrine tumor common sites. Insulinoma is equal in head, body, tail, carcinoma is more common in Passaro triangle. If not there, go for duodenum. Glucagonoma common in head, VIP-oma common in tail of pancreas. So these are the high yield points from neuroendocrine tumors. Please don't forget necrolytic migratory erythema seen in glucagonoma. So then comes the last heading in tumors, that is cystic neoplasms of pancreas. Cystic neoplasm of pancreas. I'm just going to make one image. You remember this image for your exam. So just remember this image, you can answer all the questions. Though this is very important for super specialty exams. For PG, just few questions are coming up in the exam. Cystic neoplasms means neoplasm in the pancreas containing fluid. So the first important cystic neoplasm is in the head of pancreas, known as serous cystic neoplasm. This is known as serous cystic neoplasm. Just I'm writing and drawing. You just remember this one image. So the serous cystic neoplasm is most common cystic neoplasm. It is most common in head of pancreas. It contains clear fluid and it is mostly benign. So most common cystic neoplasm is serous cystic neoplasm, most common in head. It contains clear fluid. It is benign. It is common in females than males. So please remember, it is common in females than males. And coming to this neoplasm, which is seen more commonly in the body and tail, what is it? This is the one neoplasm which is commonly seen in body and tail, known as mucinous cystic neoplasm. Mucinous cystic neoplasm is common in the body and tail. It is more common in body and tail. And very interesting point is, it is most common in females. Very common in females and very rare in males. In fact, it is exclusively seen in females, or otherwise it's very common in females. And it is usually malignant. And it contains mucinous fluid. Present. And please don't forget, FNAC of all these tumors, what will be the finding? FNAC of serous cystic neoplasm shows glycogen-rich cells. Will have glycogen-rich cells will be positive. FNAC of mucinous cystic neoplasm is going to come as an MCQ for you. That is ovarian stroma is present. They will have ovarian stroma plus. So ovarian stroma is present in mucinous cystic neoplasm. Glycogen-rich cells are seen in serous cystic neoplasm. So is there any other tumor? Cystic neoplasm tumors? There are so many tumors. Please don't forget the one which may be asked for your exam. This is a duct, and the cystic neoplasm arising from the duct, more commonly in the head. What is it? The one cystic neoplasm which is arising from the duct is this. Because it is arising from the duct is dilated both distally as well as proximally. The duct is dilated. The duct is dilated both distally and proximally. This is therefore known as intraductal papillary mucinous neoplasm. Intraductal papillary mucinous neoplasm, because it arises from the ducts like this. It is most common in head. It is equal in male and female. It is mostly malignant. It is mostly malignant than benign. So it is more malignant. It is more malignant. FNAC shows mucin content. FNAC shows mucin content. So all these tumors are diagnosed. Best investigation of choice is EUS. Investigation of choice for all this is EUS guided FNAC and fluid analysis. So investigation of choice for cystic tumors is endoscopic ultrasound guided FNAC or biopsy and fluid analysis. Endoscopic ultrasound guided, we not even tell FNAC, we can even take biopsy. Endoscopic ultrasound guided biopsy, through the stomach we go inside and take biopsy and send the fluid also for analysis. The fluids will have increased CEA. So please remember, one of the important methods to differentiate it from pseudocysts, these cases will have increased CEA in the fluid. Fluid analysis may have increased CEA. And in this I want to tell you, but usually we will take CT scan. In CT scan we will get a cyst, then only we go for EUS. So what are the CT scan findings? CECT of serous cystic neoplasm shows sunburst calcification. Sunburst calcification is seen in serous cystic neoplasm. Mucinous cystic neoplasm, expected MCQ for this year, will show you eggshell calcification. The calcification will be looking like a eggshell. The peripherally the eggshell-like appearance will be there. Eggshell calcification. Serous cystic neoplasm will show sunburst calcification. IPMN on CT scan will show dilated duct, both proximal and distal, dilated pancreatic duct present. And when you do ERCP for a IPMN, that will show you an appearance. That question is already being asked in NEET super specialty. What is it? The ampulla will show what appearance? The ampulla will continuously secrete mucin and have this appearance. What is this appearance known as? Fish mouth appearance, like a fish mouth. You see, this looks like a, though I'm not drawing it perfectly, you can see this is looking like a fish mouth appearance. Looking like a fish mouth appearance. This question is an expected question. So please don't forget the three cystic neoplasms. Serous cystic neoplasm is the most common cystic neoplasm which will have glycogen-rich cells on FNAC. CT scan will show you sunburst calcification, and mucinous cystic neoplasm will have ovarian stroma on FNAC and will show you eggshell calcification. IPMN will have dilated pancreatic duct and will have fish mouth appearance on side viewing scopy. Actually, it should not be said as ERCP. On a side viewing scopy, if you see the ampulla, it will have fish mouth appearance. Okay, so these are the three cystic neoplasms commonly seen. Another one cystic neoplasm is SPT, solid papillary tumor, which is also a type of cystic neoplasm. It's also known as France tumor. France tumor, solid papillary tumor or France tumor is another cystic neoplasm. So please don't forget these tumors of pancreas. These are the various tumors of pancreas which are asked in the exam. So though I have discussed a little bit too much, but these are all high yield MCQs for institute exams. So please don't forget, what is the most common mutation seen in pancreatic cancer? KRAS mutation is the mutation seen in pancreatic cancer. Second is P16. And which hereditary risk factor has 100-fold risk? 100-fold risk is seen with Peutz-Jeghers syndrome. Please don't forget. And this appearance is what I told you on a barium male having a reverse 3 or epsilon sign. And this is what I told you, double duct sign. You can see the ducts are separated, double duct sign. So this is the stool color in these patients known as Thomas sign. It is a clay silver stool. Because of obstructive jaundice, the patient will have with obstructive jaundice and melanoma mixed together, the stools will be having silver stools. This is known as Thomas sign. Okay, it looks like a Thomas silver stool. So this is a typical picture showing you dilated gallbladder and a periampullary cancer. So this is typical Courvoisier law. You can see the typical Courvoisier law. So please don't forget, AGC 8 addition, I already told you, T1 is less than 2 cm, T2 is 2 to 4, T3 is more than 4, T4 means involves celiac axis, SMA and common hepatic artery. So no need to know about notes and all, just remember T staging. And what is borderline resectable lesion means? If the lesion is involving more than 180 degree of portal vein and superior mesenteric vein or less than 180 degree of celiac axis and SMA is known as borderline resectable tumor. So this is a CT scan showing a tumor in the pancreatic head. We should do pancreatic protocol CT at a 2 to 3 millimeter cut is made at the level of pancreas, and this is a typical Whipple's operation. You can see the stomach is cut here, duodenum, jejunum is cut here, and we remove this, and we have done 3 anastomosis: hepatico-jejunostomy, gastro-jejunostomy, and pancreatico-jejunostomy. This is typical Whipple's operation. The most common complication of Whipple's operation is delayed gastric emptying in 18% cases. To prevent this delayed gastric emptying only, we do this operation known as Longmire-Whipple's procedure. So in Longmire-Whipple's procedure, you can see the pylorus is preserved. So this is the most common after, not Whipple's, it is common anatomy after Longmire and Traverso procedure. This is pylorus preserving Longmire and Traverso procedure. So this is a picture showing you a Whipple's. So this is a periampullary tumor which is shown here. These are all some of my patients. And this is known as necrolytic migratory erythema. Seen in which condition? You get necrolytic migratory erythema. Seen in glucagonoma. In glucagonoma, you get necrolytic migratory erythema and diabetes. Most common in head, it is malignant. And VIPoma is common in tail. So these are all necrolytic migratory erythemas. And this is a cystic neoplasm. I told you there is a table column provided in your material. Please don't forget this. And in mucinous cystic neoplasm and IPMN, the CEA content will be high. CEA is low in serous cystic neoplasm, but it is high in mucinous and high in IPMN. I told you serous cystic neoplasm is mostly benign, so therefore no need of surgery in serous cystic neoplasm. Other cases, mucinous and IPMN always needs resection. They need resection. So please remember, mucinous cystic neoplasm has malignant potential, IPMN has malignant potential. Therefore, I will do resection of these cases. So please remember this table column high yield for your exam. So you can see the sunburst calcification here. This is sunburst calcification in serous cystic neoplasm. This is IPMN showing dilated duct, and this is one of my patient I have operated a mucinous cystic neoplasm. You can see the video showing you the cystic neoplasm in the tail of pancreas. I have done a resection at this level. So this is a mucinous cystic neoplasm distal pancreatectomy. It is splenectomy done. So solid pseudopapillary tumor, also known as France tumor, is common in young women, though it is not truly cystic. It is coming under this classification. Okay. So ERCP shows fish mouth lesion or fish eye lesion in IPMN. Please don't forget, IPMN shows fish mouth lesion. So that's about the pancreatic tumors, one of the important chapter, pancreas. Please focus on these topics and all the questions I told you. Okay. Thank you.